So this is a 67-year male with the comorbid hypertension and chronic tobacco chewer. He presented to our OPD with complaints of hoarseness of voice since 3 months and dysphagia since 2 months. And on examination, the oral cavity, there was no any visible lesions. It was grossly normal, and there was no any palpable neck nodes. So I'll ask Dr. Shiva sir. So sir, in this case, how should we go further when patient presents with hoarseness of voice and dysphagia?
See, as you said, I mean, you have to ask the history of whatever the symptoms are. I mean, since I mean, I'll be talking about in general larynx and hypopharynx, and so mostly if it is any of the laryngeal subsides, there would be presentation of hoarseness would be more common, and neck swelling if it is a supraglottic primary, and if it is a hypopharyngeal primary, then most probably the patient will have swallowing difficulty and odynophagia. And then voice change may not be a common symptom. Of course, it can be common once it is T3, or definitely for a T4. So we need to go into those symptoms, and we need to ask whether the patient has any history of difficulty in breathing. Sometimes they may say they may not have, especially when you're evaluating advanced tumor. You need to carefully evaluate for a borderline airway. So in that case, you have to ask whether the patient is able to, I mean, if the patient is not coming upfront with that history, how you can elicit that history is by asking whether the patient, has any difficulty in breathing, whether he's able to, lie down and sleep at night, without much problems, difficulties, or whether he's unable to sleep and has to frequently get up, from this lying down position. So all these things will give you a hint that the patient is, though he's not coming up with the symptoms of difficulty in breathing, has a borderline airway. And we'll go, I mean, as you're going ahead with the examination, maybe we can discuss the findings and examination findings, what you need to see subsequently. So these are some of the things which I thought I should tell as far as the history is concerned. And of course, you would probably elicit the history of habits like alcohol consumption, tobacco consumption, substance abuse, that is, because that definitely is a common, aspect in these, most of the head and neck cancers, as you know. Okay, if there's any other specific question that you want me to ask, I can try to answer that.
Okay, sir, I'll ask you some specific questions also. Nandini ma'am, would you like to add something else in history taking at this moment?
No, I think sir has covered all the points, so I think probably we'll move to the examination.
Can I just make a point here?
Yes, ma'am.
So when you talk about, I think in this previous slide, you've talked about habit, smoker, addiction, tobacco. So I think it is important for you to qualify this further and better, meaning smoked, smokeless, quantity and number of years. Okay, because you could then calculate the pack years and the risk attributable to causation of a particular kind of cancer. Yeah.
Okay, ma'am. Okay.
Yeah, just adding one more point to the same thing now that Madam has said that I just forgot previously, is that even the tobacco, whether it's smoked or smokeless, and we have a literature supporting that use of smokeless tobacco also is associated more commonly with hypopharyngeal malignancy. So that is another history that you probably need to elicit every time, because if you document that, you may have a good amount of rate. We already have that, but it's essential to document and correlate each time.
Okay, sir. Okay, ma'am, anything specific we should ask about family history in head neck cancer?
The main thing that you may want to ask is essentially whether there is any other history of any other member suffering from cancer, because essentially for hypopharyngeal cancer, I don't remember, but I don't think you've got any familial types, but only about the association of any other. I mean, this is just essentially a formality rather than anything else, and may to some extent reflect more of socioeconomic things than anything else.
Okay, ma'am. Okay.
Or otherwise, the reason to ask is, like if you've got a post-cricoid malignancy and, in the area, things like that, but not family per se.
Okay, ma'am. I asked this question regarding this Plummer-Vinson syndrome, which is common in females, and they may have associated
Yeah, other things. So that's why I said post-cricoid, but then we know that
post-cricoid.
this lady, this man is not post-cricoid. So fine, but yes, it may be just for completion's sake in this particular situation, you may want to ask. Yeah.
Yes, ma'am. And next part regarding to Dr. Siva sir, because right now he's having no palpable node. Suppose if this patient is having a palpable nodes at level 2 or 3, so how should we sir examine for the extranodal extension? Just in brief for about to know our students.
Yeah. See, clinically, how would you, anticipate an extranodal extension, or is that by assessing the mobility of the node? Of course, size. Any node, even a node which is smaller in size can have extranodal extension. That's a different aspect. But then, if the node is not is the mobility of the node is restricted, that means it's involving the underlying structure or the structures around it. So which is probably due to extranodal extension. And also obviously when there is any fungation of the node, that obviously indicates that there is an extranodal extension of the disease. So the mobility of the node will give you an idea as to one, whether it's involving the surrounding structures, and also a gross idea as to, if you're contemplating surgery, a gross idea as to about its resectability. A hard fixed node points towards an unresectable node, but sometimes it may not be the case, but mostly it is the case.
Okay. Thank you, sir. Is there any question right now from any student, especially those who are posted in head neck OPD or those who are in solid 2? Shashwat, Abhishek, Hemant. I think they don't have any question right now. So right now, sir, with the based on history and examination, means on examination there was no specific find grossly. So this patient was further examined with the FOL, and there was a right this in the right right sided this glottic area. There was also proliferative growth involving the right area epiglottic fold, right false vocal cord, and this base of tongue, base of bilateral vallicula and epiglottis was normal, and the left side also the true vocal cord territory was normal. So to Dr. Siva sir, means
Yeah.
I just wanted to means how this for FOL, how should our student approach?
See, when you're doing an FOL, I mean, this also holds true when we do a direct laryngoscopy, but then we'll discuss that later. But when we are doing FOL, we need to look for structures in an orderly fashion. Usually it will be better to go from above downwards, especially in an FOL, because then you will not miss out on some of the findings. So when you're doing an FOL, so what you need to see is the first thing that will be visible once you're in the area of interest is your base of tongue, the vallicular, and the pharyngoepiglottic fold. So you just see whether there's any disease. These are the uppermost aspect once you do an FOL in the area of interest. And then you also look at the epiglottis, and then you go into the array epiglottic fold and the lateral pharyngeal wall. And then you look at the arytenoids, the false cord, glottic chink, and then you see the piriform aperture on either sides and the posterior pharyngeal wall. So you can see this much, in an FOL. So of course, if there is any growth, you will want to map the extent of the growth as to what are the structures involving, as the structures which I just mentioned from above downwards. That is one thing. The next thing is how much of the glottic chink that is available, the glottic airway. Does that look inadequate? The other thing is the mobility of the cord. So you ask the patient to phonate E or K or whatever. So you just see whether the cord is mobile or not. And and then the next thing is, if the growth is not very, sometimes the growth may not be very obviously seen. So you'll have some pooling of saliva. If it is there on one piriform fossa, then the opposite piriform fossa, if there is any pooling of saliva, that may indicate that the lesion is not just in the piriform fossa, probably it's going below the piriform fossa into the cricopharyngeal area or something of that sort. So that's why there is pooling of saliva in the opposite PFS also. So these things give you an idea. First, you need to know the extent. You may not get the entire extent sometimes, but when you can get it, it's well and good. If you don't, you just have to look for these findings and have a mental picture as to where else the lesion could probably be extending. So these are the things that you need to look at FOL.
Okay, thank you, sir. Sarbani ma'am, before FOL, should we have any other method to examine the patient?
It is always good as in to do an examination in the OPD. So one is of course FOL, but then we may not have recourse to an FOL like you and me because of in this setup. So I think it would be good if you could also do a Hopkins evaluation. Yes, but in the current scenario, you would have to be careful simply because of the COVID business. Otherwise, I think an Hopkins is also a good examination that you could do. Of course, it may not always be great because of you need the patient's cooperation, but I think a Hopkins is also good and it should be used if I think it can be used. What do you say, Shiva?
Yeah, I'm absolutely agree with that. So that's what I just was answering in the chat box as well, that Hopkins, in fact, actually, when I was doing my fellowship we never had done Hopkins. So we used to, in fact, do all the laryngeal examinations with an indirect laryngoscopy, that ideal mirror, indirect laryngoscopy mirror. But then now we have moved beyond that, and now the minimum that you need to do to have a proper examination is the Hopkins. And now with the onset of COVID, things have changed. So FOL is sort of kind of better so that you don't have to go closer to the patient. You can see on the monitor. So that way we are now doing more FOLs than Hopkins. But then just to say that when you're doing a Hopkins, you need to be very careful. You have to explain the patient as to what you're going to do. Otherwise, most of the time what we do is we go and touch the posterior pharyngeal wall or the base tongue, and the patient gags and you're not able to see. And when you're doing Hopkins, it has many times happened that the patient may have an advanced glottic or an hypopharyngeal growth. When you pull the tongue in a very rude manner, that can itself instigate precipitate a stridor for the patient. It has happened many a times like that. So you need to be very careful. You need to explain the patient, ask the patient not to hold his breath, and explain what you're going to do. Hold the tongue gently. If you're necessary, spray 10% lignocaine in the posterior pharyngeal wall, and then without touching the posterior pharyngeal wall, base of tongue much, try to look into the glottis, and then we have to be quicker. So it comes with some amount of learning. I mean, as you do more and more Hopkins, you get better at it. It's as simple as that.
Okay, sir. Nandini ma'am, would you like to add something in this examination part before going further?
I think everything has been covered except this one question which is asked in the chat box by Abhishek. So I would like to ask Shiva sir, if FOL and DL scopy both are done, the question is which findings are to be preferred?
I can tell that out. I just was typing it in the chat box. So I think the DL scopy findings will give us more information than FOL. So always any laryngeal or hyperpharyngeal cancer, we would prefer to do a DL scopy to do the mapping, especially the advanced disease and the ones which you plan to consider for surgery. Because here, once the patient is under anesthesia, part of the DL scopy is as you come out, you palpate the base tongue, the tonsil area, which again tells the upper extent, which may not be obviously visible when you're doing an FOL. And also when you do an FOL, you go below the retroarytenoid area. That is, you lift the larynx up, you see bilateral piriform apex, and then you go towards the cricopharynx, and you see whether the disease is going up to the cricopharynx. So all these things give you idea as to what is the inferior extent as well, which you'll not get with an FOL. FOL just tells you up to the piriform fossa. We cannot see the piriform apex in the fiber optic laryngoscopy. We can just see the arytenoid. We cannot see anything below the retroarytenoid area. So if there is any, and the postcricoid area cannot be visualized. So if there's any disease in these areas, it can only be picked up by a DL scopy. And that makes a lot of difference when you do consider surgery, because the extent of resection and the reconstruction plan would change accordingly. I hope I've answered the question.
Yes, sir. So now in short, while when we are in head neck OPD, we should remember that the head neck cancer is not only about the survival. We should also remember that in head neck management means approach and management will be depend on in 2-3 aspects. In addition to survival, the cosmetic and function is more important. So while taking history, we should ask regarding functions related to swallowing, speech, and breathing assessment, airway assessment. These all should be taken care during history taking and examination. Except for external examination, we should be having adequate skill to do the Hopkins, so that we can do the adequate mapping of the disease as much as possible in the clinic, in the OPD only. So in this case, for going further, this patient underwent DL scopy, and there was a ulcer-proliferative growth at the middle of the right piriform sinus and right involving the right aryepiglottic fold and arytenoid and adjacent false cord, and also the bilateral two vocal cord was not involved, and glottic chink was adequate. Lateral of the and lateral side piriform sinus apex was free, and post-cricoid region was free. So this was the DL scopy finding.
The most important finding here is the mobility of the cord. I'm not sure if it's a bilateral true cord vocal cord mobile. Normal is written, but was it
was
mobile?
mobile, sir. It was
sorry?
Mobile, sir. Yes, sir, it was mobile.
Yeah, so that becomes a very important finding as well. So that needs to be documented.
Yeah, so right now, as per current 8th HNSCC this staging, if any hemilateral or vocal cord involvement with fixation, it makes disease T3. So that is a very important finding in the DL scopy or examination part. Nandini ma'am, would you like any additional finding in this this DL scopy?
No, as sir has mentioned, the mobility of the vocal cord is important. And the glottic chink has also been mentioned that it's adequate. So no additional findings from my side, unless Shiva sir wants to add something.
No, that is, I mean, of course, DL scopy would be done under anesthesia. So actually the vocal cord mobility will be best assessed in an Hopkins or an FOL. But then sometimes you may not be very accurate. So what is done in a DL scopy is that you look for the mobility of the arytenoids. So as you said, fixation of the hemilarynx means you just with your suction tip or an instrument, you would want to just move the arytenoid and see if the mobility of the arytenoid is not visualized, and then you'll palpate the paraglottic space if there is a doubt. So in those situations, sorry, just a minute. Yeah. So in those situations, you would want to assess the paraglottic space. So these are some of the additional things that you'll be doing in a DL scopy. Many times it may be documented, many times it may not be documented. So, but then you should know that these are the things that you need to look for.
Okay, sir. So during this, biopsy was taken during this procedure, and his final HPR came as a squamous cell carcinoma poorly differentiated. So I would like to ask now Neha Mittal ma'am, as per current this diagnosis, WHO diagnostic purpose, what all things we need to see in the this HPR of this hypopharynx.
Good morning, everyone. Can you put up my slides, or
Yes,
we'll discuss them later?
No, I'll just put.
Okay. Yeah. So these were the histopathological findings in this case, and as you can see that there is a squamous mucosa. Squamous mucosa, these are squamous mucosa line fragments. There are multiple fragments, and these are squamous mucosa line fragments. The mucosa in this case did not show any evidence of dysplastic lesion. However, the subepithelium, the submucosal region appears quite busy and blue and busy. Next slide. Yeah, this is a little bit more higher power to show you that this overlying mucosa, that pink band on top, that is not showing any that is showing nice maturation. There is more pink at the top and less pink basal cells at the bottom and more pink cells at the top, whereas the submucosal region is the one which is of concern here, which is showing these collections of blue cells. Another higher power, please. And as you can see, this is the highest power in which we can see that there are these cords of cells which are atypical, which are malignant. These are infiltrating in the form of cords. These cells have a large nuclei, vesicular nuclei, multiple nucleoli, and they appear to be in a continuum of cytoplasm, giving this cord-like pattern. There is no obvious squamous differentiation, which is in the form of keratin pearls, which is extracellular keratin, or intracellular keratin, in which you have individual cells showing that pink, hyper pink eosinophilic keratin in their cytoplasm, none of which is visible here. What is visible is that in between these tumor cells are very small hyperchromatic dark, like black bindis, all those cells are scattered in between these big cells, and those are basically the lymphocytes. This is a morphology that we call as lymphoepithelial type of morphology. There is no obvious squamous or glandular differentiation. So here in this situation, it is what we can see that this is, and there is abundant mitosis and atypical mitosis as well. So this kind of a lymphoepithelial morphology, undifferentiated, or so to say poorly differentiated looking tumor, generates a lot of differential diagnosis in all sites. This is the kind of squamous carcinoma, poorly differentiated, can have this kind of histology. A non-keratinizing HPV associated tumor can have this histology. Adenocarcinoma solid type can also have this histology, and there are a host of other tumors like nut carcinoma, which can have this undifferentiated like histology. Even melanomas can have this kind of a cord-like pattern, and epithelioid melanomas can very well mimic an epithelial tumor. So with all those differentials, if you have no differentiation, you need to prove what this tumor is, because the differentiation may not be apparent on histology, but may be apparent on immunohistochemistry. So with that in mind, an immunohistochemical panel was done in this situation. Next slide, please. Okay, so this is the cytokeratin, the A1A3 stain, which beautifully highlights the internal control is your squamous epithelium on top, and now you can see that band beautifully, and you can see the entire subepithelium, now submucosal region, has lit up with A1A3, which is pan-cytokeratin, which is an epithelial marker. So this tumor is showing this nice membranous positivity for an epithelial marker, and hence is an epithelial tumor. Next slide, please. Okay, this is just the high power of the A1A3. Okay, this is as compared to the previous, here you just see these brown dots of positivity. Why this is different from the last? Because this is P63. I don't know why my labeling is not visible in the slide. This is P63, or this is the squamous marker. This is the squamous marker, and that is this P63. Even your surface epithelium is positive for it, which serves as the internal control, and the entire tumor in the submucosal region shows P63 positivity diffuse. So this tumor is either squamous or has a squamous, has positivity for squamous markers. Why I say that? Because in head and neck area, why I'm not directly calling it as squamous carcinoma in this at this point of time with P63 diffuse positivity, because a lot of head neck tumors now show positivity for squamous markers, which includes nut carcinoma, which includes INI1 deficient SMARC, B1 deficient carcinomas, and a host of other head and neck tumors can have, or myoepithelial carcinomas. All these can have positivity for squamous markers. So just the positivity of squamous marker does not make it a squamous carcinoma. We have to rule out other possibilities as well. Next slide, please. This is the P16 immunohistochemistry in this case, and as you can see, your surface again serves as a control, and it is negative for P16, and the entire tumor underneath in the submucosal region shows diffuse positivity for P16. P16 has to show nuclear as well as cytoplasmic positivity. Next slide. This is the nut stain. Again, as I said, nut is being diagnosed in all the places, and larynx and hypopharynx are known sites for nut. And this is nut, which is important to rule out because there was no differentiation per se. And this is nut immunohistochemistry, which is negative in this case. So this is not a nut carcinoma. Otherwise, we would have seen diffuse positivity, nuclear positivity for nut IHC. Next slide. Is there any other
Yeah, ma'am,
Yeah,
so
this is just the
P16.
P16. This is P16 on higher power to show you the diffuse nuclear as well as cytoplasmic positivity. Both nuclear and cytoplasmic positivity in upwards of 70% cells is required to say that the tumor is P16 positive at any subsite at the moment. So as you can see, this tumor is diffusely positive for P16 both in the nuclei as well as cytoplasm. So this is a tumor which is A1, A3 positive, P40 positive, P63 positive, squamous marker positive, and P16 positive. Negative for NUT. INI was retained, and I think maybe S100 on one more marker was also done, which was also negative. So overall, this is a squamous carcinoma, P16 positive, which lacks any different non-keratinizing squamous carcinoma, P16 positive.
This was from INI.
This is INI1. This is INI1, which INI1 is a ubiquitously expressed marker. It is positive in all tissues of the body and all tumors of the body. It is the loss of INI1 which indicates an activation of the SWI/SNF pathway, which is an epigenetic phenomena, and it is loss of this marker which is interpreted as positive. So here it is positive, which means that this is not INI1 deficient, and this tumor is INI1 retained.
This was one from LCA, leukocyte common
This is
antigen.
leukocyte common antigen. LCA was done because the tumor cells had a very undifferentiated, as I said, and this highlights the lymphocytes. Lymphocytes in between the tumor cells and highlights the lymphoepithelial nature of the tumor. This is important to know that you have to know the cell in which you have to look for the positivity. The LCA per se on low power looks lot of brown. There appears to be a lot of brown positivity, but the tumor cells which are actually in between are looking and are gray are actually negative for LCA. So where you are looking for your IHC positivity, IHC per se does not give you the result. You have to interpret it in terms of the tumor that you're looking at. So this tumor is negative for LCA, so not a lymphoma. So as I said, this is a P16 positive non-keratinizing squamous carcinoma of the hypopharynx.
Okay, thank you, ma'am. This was all this we have. Right now, just next question is to Shiva sir. Suppose sir, this patient also had a neck node. So what will be the preferred modality of tissue diagnosis? Whether it should be from node or it should be from primary hypopharyngeal mass?
Always, I think it should be from the primary as much as possible. And the nodal disease can supplement that. But then there might be situations where, it may not be possible. Like if the patient, has a borderline airway, or you cannot take him under general anesthesia, or many times in the COVID situation where if you can just see a growth in the FOL, because we cannot, we have done it when there was, the first and second peak that was there of the COVID, that we just went with the clinical radiological findings, and that was there in the if there was a growth in the larynx or hypopharynx, and then we just supplemented that with an FNA and went ahead. But ideally, the diagnosis should be from the primary, and the node can supplement that.
Okay. So and suppose sir, if this patient only had a node, and in this dual or FL, there was no any gross mass or ulcerative lesion, and only having some rough areas. So at that moment, what we should do?
See, we would always try to do a biopsy from the most suspicious part. So whatever is not looking normal, you need to do a biopsy. So to help you do that, sometimes we may use the narrowband imaging as well. We have that, but then so that will help us identify the abnormal, mucosa. It depends on the vascular loops. So there are various patterns of it, and that helps us pick up the normal mucosa from the abnormal. And that may help you do that when it is like really diffuse and you're confused as to which side to do your biopsy. But otherwise, when you do a DL-scopy, you can clearly identify the normal mucosa with the abnormal one, and you'll have to biopsy that and rule out that that is not the possible primary site.
Okay, thank you, sir. Next question is Sarbani ma'am. Ma'am, if patient also having node, would you like to do FNA, or will be happy with doing the diagnosing this with the hypopharyngeal biopsy?
See, if the node is clinico-radiologically appears malignant, and we have a positive biopsy from the primary, I wouldn't actually go for an FNAC from the lymph node also.
Okay.
It's only when, you know, you have, say, this is a T3 or rather say a T1 or a T2 lesion where you are, where the presence or absence of a lymph node, positive lymph node, is going to impact your management. Then it would be important for us to ascertain that the lymph node is involved. Otherwise, for a T3, T4, where it may not impact or change your management to a great extent, I wouldn't go if I have a positive biopsy from the primary.
Okay, ma'am.
Ma'am, if you are in periphery, how often you would ask such a set of IHCs and like ruling out all other poorly differentiated malignancies in a resource constraint situation?
Who are you asking, Neha or me?
In general, because clinicians also
I
would be
wouldn't
interested.
actually, if the pathologist was clear that this is a squamous carcinoma, I really wouldn't push for additional markers, because the squamous carcinoma is enough for me to kind of decide on what should be the management. But yes, if there is a dilemma whether this is an NEC or something else, then yes, I may ask for further IHC. But otherwise, if the pathologist is sure that this is a squamous CA, I may not ask for further IHCs.
Just to add to that, I think the IHCs might be needed only probably when the differentiation is poor and they're not able to go beyond that. And also in these situations where if the biopsy from the primary comes as poorly differentiated carcinoma, and if there is a node, I'm not sure. I think an FNAC might help, just to, you know, if we are not able to do IHCs. I'm not sure if I'm right or wrong by saying this. FNAC probably might help us see if there is any squamous differentiation in the node. I'm not sure if I'm right or wrong with this statement. I think
So,
Dr. Neha may correct me.
Yeah. So, okay. Shall I? Okay. I think somebody else was asking. Please.
Shiva, my another question is, what percentage of cases you would see poorly differentiated in this region? If this region has a large chunk of poorly differentiated, that means then you will land up in a situation where squamous differentiation diagnosis would be difficult. And that means then you would need IHCs.
That's what. So the
Yeah,
person.
all interest. Sorry.
Yeah.
Sorry. Go ahead, Shiva.
I mean, generally speaking, I think that's what the pathologist also would do, is that the IHCs are needed for when there is poor differentiation, when you're not able to identify the lineage. So I think most of the pathologists would be able to tell you whether it's a squamous cell carcinoma and the differentiation. And when the differentiation is poorer and it's so poor that they're not able to tell you exactly with the morphology that it's a squamous cell or not, is when they would require an IHC. I think Dr. Neha will be the best person to clarify this.
Yeah, so all concerns and questions are actually, they're very good, excellent questions and excellent concerns. So the first thing is that, you know, head and neck squamous carcinoma is such a common and such a morphological diagnosis that practically head and neck patients are actually funding for the IHC, you know, markers for the entire rest of the DMGs, because, you know, we charge almost similar, and then IHC markers are hardly ever required in head and neck squamous carcinomas. Having said that, there are a lot of areas in head and neck where immunohistochemistry is prognostic, is predictive, and where we have to use, for example, sinonasal, salivary, and all those areas. But now we are not talking about that. We are talking about when do we need a immunohistochemical marker to diagnose a squamous carcinoma. So we do need markers like for squamous carcinoma, when, as I showed you here, that first thing on morphology will be the origin. As you can see, the entire, what I showed you first was the surface, and that there was no dysplasia in the surface. If there is surface dysplasia, that means the tumor is originating in that cell in that particular area, and that is a done thing. So if there was surface dysplasia in this, even with this undifferentiated, or so to say poorly differentiated look, no immunohistochemical marker would have been done, and we would have said that this is a poorly differentiated squamous carcinoma with in situ component seen on the surface, or maybe just a confirmatory A1, A3, P40 would have been, squamous markers would have been done. So first thing, morphology, the surface does not show any dysplasia. Second thing on morphology, absolutely undifferentiated or poorly differentiated lymphoepithelial like look. where you do not have any keratinization. If the entire tumor seen in this biopsy showed any amount of keratinization, individual or in the form of keratin pearls, again immunohistochemistry would not be required, and this diagnosis could have been made on morphology. But 10 to 15% of cases, or maybe even more, are such where there is no differentiation on morphology, where immunohistochemistry, and as I said, that newer entities are being diagnosed with different prognostic and treatment related implications, and that is why immunohistochemical markers are performed to confirm a particular diagnosis. Having said that, hypopharyngeal and hypopharyngeal tumors are so to say notorious for having to address Abhishek's concern, are notorious for having a very poorly differentiated histology. But most of the hypopharyngeal tumors have a poorly differentiated histology in the form of a basaloid looking squamous carcinoma. Those carcinomas actually resemble adenoid cystic, but they do have a squamoid appearance, but they have those adenoid cystic like areas, large cribriform islands of tumor cells, and again surface this thing. This probably is a biopsy which is taken from the edge of the lesion or somewhere where the tumor is infiltrating submucosally. So that is why we do not see any surface dysplasia, and per se this tumor did not have the typical basaloid look of pyriform sinus, which pathologists even recognize in a metastatic lymph node. So because of those, and because nut carcinomas are known now in these sites, and there are other types of salivary gland related tumors which can also happen. Salivary duct carcinomas can have a similar histology. So that is why, because of all those concerns, an immunohistochemical panel was done in this case. But this will be, you can say, around 10% of the represent 10% of tumors in the squamous carcinoma realm in the head and neck area.
Yeah, Dr. Neha, I have a question. Like, for example, if there is a poorly differentiated growth in the larynx or hypopharynx and he has a node, now, is it possible that in an FNA you can still be able to comment that it's a metastatic squamous carcinoma, though the biopsy says it's poorly differentiated?
So by and large, if you go by the tumor biology, it is said that the metastatic clone is actually the most poorly differentiated clone. It is the worst clone. So considering that the tumor is so poorly differentiated at the primary site, it is unlikely that the tumor will show a differentiated histology at the metastatic site. So that is why keratinization to be seen in an FNA, when you are not seeing it on histology in the node, is quite unlikely. But then tumors, don't read books, and maybe that this is a biopsy. This is not this is just a representation of the entire tumor, and maybe other areas in the tumor are showing keratinization, and those are the areas which are metastasized to the node. So it might or might not help. But looking at this tumor, this histology, I will not think that FNA of the node will show keratinization.
Right. Thanks. I may not show keratinization, but then will that help in telling you it's a squamous cell carcinoma? That was my question. I was just eager to find that out.
No.
Okay. No. Thanks.
Okay. I would like to ask Neha ma'am to stay with us, because we have some few more questions related to pathology. But because of shortage of time and Sarbani ma'am has to leave at 9:30, we'll just go ahead with the next part. So further staging was completed with the CT scan of this patient. And there was a 2.4 into 2.1 to 2.6 centimeter mass in the pyriform sinus, and as per detailed reporting, it was a T2 lesion. So I'll just ask Abhishek sir to highlight further on the staging of this hypopharyngeal cancer based on the CT scan, and which modality we should prefer while doing the staging scan, MRI or CT scan or PET CT scan.
Yeah, so for the hypopharynx and larynx, because of the ease of acquisition and you have less chances of getting motion artifacts, CT scores over MRI. Like MR, if you subject a patient to MR, there are chances that the patient would have motion artifacts and swallowing artifacts, and then it becomes difficult to read the scan. And MR only would be used as a problem-solving tool. That too very rarely if you have like cartilage involvement, suspicion of thyroid bone involvement, or a thyroid cartilage involvement, or if you have suspicion of a post-required region extension, which is not very sure on CT scan. I'll just show the scan. If you can, is the screen visible?
So I'll make you host. And
yeah. No, I have changed my camera. So if you can see my camera. I'm showing,
yes, sir, it's visible, sir.
Yeah. So I'm starting from the cranial aspect of the case, and we're just seeing the base of tongue over here. This is the base of tongue, and these are the tonsillar folds. I'm going down, and then you see the free edge of the epiglottis over here. This is the free edge of the epiglottis. Going further down, you see the vallicula, and there's a small nodular growth which is starting to appear now. And this U-shaped structure is the hyoid bone, the first U-shaped structure. So if you go down, you can see the hyoid bone in full extent. This is the hyoid bone. This is the coming to the fixed edge of the epiglottis, and this is the pre-epiglottic space. Going further down, the tumor is now very well visible. This is the tumor, and this is thyrohyoid membrane over here. And this is the pre-epiglottic space, and this is the fixed edge of the epiglottis over here. This is the fixed edge of the epiglottis. So if you go further down, these are the medial and the lateral wall of the piriform sinus. The tumor is predominantly on the medial edge of the piriform sinus. The lateral edge is not showing any thickening. And if you go further down, the complete occlusion of the apex of the piriform sinus is seen. No significant any post-cricoid region extension is there, but the tumor is going down at the level of the fat, which is seen at the level of thyroid cartilage. So this another U-shaped structure or V-shaped structure is the thyroid cartilage now. And going further down, there's some soft tissue and the bulge over here at the level of false cords. And I see certain amount of edema. It can be a inflammatory change at the level of true cords. So this is the level of true cords. The true cords can be identified at the level of the, I'll just change the window. So this is the cricoretinoid joint. The moment you see cricoretinoid joint, that means the vocalis muscle is there, and the vocalis muscle inserts at the anterior commissure. So you seeing this particular plane, that means you've reached the level of the true cord, and this is the true cord level. It's more denser than the false cord. So if you see the false cords, they have fat, and the true cord, because of the muscle content, they are more darker. So that there is some slight edema and the bulge at the level of true cords as well. Apart from that, we try to see in hypopharyngeal cancers pre-epiglottic space, which is very important for commenting on the outcomes of the patient. A significant more than 50% involvement of the pre-epiglottic space. So this is the pre-epiglottic space. I'll just enlarge this. This space over here, this gray space over here is the pre-epiglottic space fat, and this starts from the hyoid ligament. So this is the epiglottis. You can appreciate the epiglottis over here. This is the free edge of the epiglottis, and this is the tumoral growth on the posterior surface of the free edge of the epiglottis, which is going down. There is minimal extension into the pre-epiglottic space, which is less than 25%. Rest of the pre-epiglottic space is absolutely normal. So the tumor is actually supraglottic CA, which is extending into the false cords for sure. There is mild edematous change in the true cords. The cartilages we usually tend to see on the bone algorithm images. I'll show you what is the difference between bone algorithm images. So this is a bone algorithm image. In a bone algorithm image, you can see the marrow very well, and that's what you want to see when you are looking at the cartilages. So the cartilages are seen over here. So I would be very interested in seeing the hyoid bone also, because the tumor was very close to the hyoid bone. So the tumor is closely abutting the hyoid bone, but there are no erosions at the level of the hyoid bone. So it's just the abutment of the hyoid, and going down, space fat is involved. So this is a tumor which is supraglottic CA involving the false cords and with minimal extension into the pre-epiglottic space. The cartilages are normal, and yeah, that's it. There are no nodes. I had seen the case, so there were no significant nodes in this particular case. But if because it's a early T, it's less than T4A, patient could be a candidate for CTRT. I would be very interested in reporting all the nodes possible, because that would change the management of the patient and outcomes also.
Actually, I would like to request Keshav to go back to that CT scan which he put up in his slide. If we can just do that. There's one finding. No, the next slide. Yeah, this slide. So there's one. So no, the previous one, Keshav. Yeah. So there was one finding which I would be interested to look at if I'm doing a minimally invasive procedure in this patient. Of course, he's not a candidate for any minimally invasive procedure. But then I just wanted to point this out. If you can see the carotid, the artery here, the ICA is more submucosal and it's in the pharynx. So if I'm doing any minimally invasive procedure, this is what I need to look at. And I would be asking my radiologist as to whether, for these things, and also before going ahead for surgery, this is what would be important to look at, because if I do any procedure here, if I incise the mucosa, I have the carotid right beneath. So I need to be careful. So while doing any minimally invasive procedure, and this is what we need to look at. Just thought I'll add this point because this was just staring at me. Yeah.
Especially the left one is more superficial than the right.
Yeah, the left one only. The left one. It's almost inside the pharynx.
That becomes an important point when you have any robotic surgery planned.
Exactly.
These are like medially placed carotids, so that's very important when you have planned a robotic surgery.
Even for a laser.
Okay, thank you, sir. So now this patient has a T2 lesion, no notes. Because of shortage of time and Sarbani ma'am has to leave, will come to the evaluation fitness for treatment and evaluation part, audiometry, and sometime later we'll directly go to the treatment part.
Sarbani ma'am has a question like, will we ask for a fluoroscopy and a swallowing? We usually would not do in this case because this patient has PFS disease. If the patient has been evaluated in a case like this, you would see pooling of the barium on one side, and I do not see any added advantage of it doing a fluoroscopy, ma'am.
Yeah, I have a point here. The point that I wanted to ask you about is essentially, you know what, if you, where is the place for doing a barium swallow with a lateral PC film in hypopharyngeal cancers? You know, because by far and large, we don't do barium swallow evaluations anymore, whether it is esophagus, whether it is hypopharynx. But is there a place, the place where we should be doing a barium swallow or take a post-cricoid film in the hypopharynx at for any indication?
Ma'am, if you're planning, it would help into the further, if post-treatment, you will have a matched analysis. If you're doing swallowing assessment, it might be of benefit to assess post-treatment swallowing with the pre-treatment swallowing. But I do not think that there is any other, apart from that, post-cricoid region, if there is pooling and there's extension to a post-cricoid region, you might pick it better than the CT.
Yeah, you know why I'm asking. Yeah, why I'm asking this question is sometimes you can have subtle mucosal involvement. So one thing would of course be that you will have to augment your DL-scopy or your FOL with an upper GI examination. And in that case, you may also want to do a barium swallow with a lateral post-cricoid film just to ascertain the inferior extent of disease.
Yeah, ma'am. Yeah.
Shiva, would you agree to that philosophy?
If you can just tell, you're talking about a post-cricoid lesion, ma'am?
Yeah. Now, supposing you've got subtle mucosal involvement, you know, which is usually not picked up on a CT scan, and your DL-scopy may not be adequate to assess the inferior most extent, then in that case, you would have to augment this entire line of investigations with an upper GI endoscopy as well as a barium swallow and a lateral post-cricoid film.
Yeah, that may help in that particular situation, yes.
Yeah, ma'am, definitely.
Okay, ma'am. So he was a T2, clinically T2 disease. So I would like to, if we are going ahead with the definitive treatment, this question is to Sarbani ma'am. How will we approach for the definitive treatment of this patient for surgery versus radiation?
Keshav, if you can just give us the stage of, what is the T and...
Sir, it's a T2 N0 and M0.
T2 N0 M0.
Okay.
Okay.
So I guess for every case, I'm sure I think Ajay is going to come back later on with the functional evaluation.
Yeah, ma'am, I'll just come because right now it is 9:25.
Yeah, doesn't matter. So doesn't matter. We'll finish it properly. So they will think so. Your speech language therapist and your audiometrist will come in. So it is important for every non-surgical treatment and also for surgical treatments to have a baseline functional evaluation of the larynx, which includes speech as well as swallowing. So that is a said today, at least in our institute. Okay. After having established a functional larynx, we could then choose these three modalities which he has listed, that is the two modalities, that is surgery or radiation therapy. Now, there is a little bit of controversy in the bulky T2. Now, if you ask me what is a bulky T2, there are various definitions, but if you go by the Veterans Affairs as well as what you had from the URTC, it would be something which is more than 6 cc. So in those cases, there is some ambiguity as to what would be your optimal management. That is, you may want to do radiation therapy with chemotherapy, or per se for a T2N0, radiotherapy alone should be enough. So that would be my take on it. But for some reason, if the patient is not willing for radiation therapy or for surgery, like how Shiva was discussing the factors that you may want to consider, I would ask Shiva to qualify it further. Otherwise, I would think about radiation therapy for this patient.
Shiva sir, what is your opinion?
So for this T2N0M0 hypopharyngeal malignancy, at least in our center we practice, and that is what I would also personally prefer, is to go ahead with a non-surgical treatment option. I think radical RT. Because for hypopharyngeal malignancy, for a T2 even, we cannot just, we have to anyway address the neck. So, also, you know, that we may have to sometimes do a bilateral neck, which may not be, and it may lead to morbidity. So I think for a T2, though in literature, the T2 hypopharyngeal cancer, there is a lot of literature with wherein they've done laser surgery and a few, you know, isolated reports of robotic surgery as well. But then robotic surgery, definitely there's not enough even prospective evidence to say anything about it, but I just thought I'll mention it. But definitely laser surgery in a lot of European centers, they probably would go ahead and do for T2N0M0 hypopharyngeal cancer also, they may go ahead and do a laser surgery. But then here in our center, we at least for a hypopharyngeal cancer, we definitely prefer non-surgical treatment option more than surgical.
Okay, Sarbani ma'am,
So,
suppose
Shiva sir, I had a question.
Yeah.
In this patient, that minimal pre-epiglottic space extension, will it preclude a laser surgery if it was to be done in our center? Would that be a factor to consider again and against it, or and go for RT?
Yes.
Or in these patients also can we consider laser surgery?
So if see, the pre-epiglottic space involvement needs to be defined well. I'm not sure if there's any minimal or it's either whether it is involved or not involved. So if it is involved, the stage becomes T3. And the patient will require chemoradiotherapy than a surgery for this T3N0M0 lesion, and definitely.
So that was my question actually, Shiva.
Yeah, sorry.
That was my question. That on imaging, pre-epiglottic space is involved, and paraglottic is also appearing to be.
So that's
involved.
what. So no.
So will it upstage T3? Like it will become T3 then?
Yeah, because as per the staging, the pre-epiglottic paraglottic space involvement would be T3, isn't it? If I'm right. So yeah. So definitely it's a T3 then, it's not a T2. So that's what I'm trying to say, tell Nandini that there is no minimal involvement. It's either involved or not involved. If it is involved, it's a T3. So in a T3, we definitely go with the organ preservation protocol. And as far as surgery is concerned, with the pre-epiglottic space involvement, we probably would not be, we can go, I mean, we have to see the extent of the disease, whether the lesion is amenable for a supraglottic laryngectomy or not. Mostly when the pre-epiglottic space is involved, it probably the patient will not conservative laryngeal surgery. Let me just put it this way: conservative laryngeal surgery. Mostly when the pre-epiglottic space is involved, it will not be amenable for a conservative laryngeal surgery as well. That is if you're contemplating any surgical options. But then for a T3N0M0, I would definitely go ahead with an organ preservation and not consider surgical options. For T3 lesions as well, there are literature, especially Steiner's group from Europe. They have a good series of T3 lesions as well, where they've done it with laser. So, but then the thing is that not many centers could replicate that. So, and also the evidence has appeared that we can go ahead with organ preservation, which probably will give you a better functional outcome as well. So that's my take on that.
So this looks like a T3, so on imaging.
Yeah, it looks like a T3. That's what even Abhishek.
It's T3 on imaging.
Okay, Sarbani ma'am, when you consider, means suppose this is a later advanced stage involving a node or T3 or T4A, when you will ask chemotherapy part as a NSCT or concurrent, when you consider?
So here comes the contentious issues. Now, by far and large, if I've got small volume disease like this and maybe an N1 node, I would still consider doing concurrent CTRT even for a hypopharyngeal lesion. But supposing this were to become an N2A or an N3B, then I would perhaps consider, or this is a bulky T3 with a lot of paralaryngeal extension to the oropharynx, then in those cases, I may consider doing, or if the laryngeal inlet is kind of compromised, patient is not in frank stridor, I may consider doing neoadjuvant chemotherapy because this is a hypopharyngeal cancer, and then you have evidence for hypopharyngeal cancers and neoadjuvant chemotherapy from the URTC trial. Also, it's the DECIDE trial, which is the only trial that has looked at advanced nodal disease. And you could perhaps think about doing neoadjuvant chemotherapy in that situation, though the findings of the DECIDE trial are equivocal because of the incomplete accrual. So my take on this is, if it's a early stage, moderate volume T3 disease, stage 3 disease, I would consider doing concurrent CTRT. But if the nodal disease is advanced, lower nodes are involved, I would consider doing neoadjuvant chemotherapy, or if there was extension to the oropharynx, significant extension, not just simply reaching the lower pole of the tonsil, compromise of the airway without frank stridor, I may consider doing neoadjuvant chemotherapy followed by concurrent CTRT, provided the laryngeal function is intact and there is no extralaryngeal extension.
This one point which Arun Balaji is mentioning here, that the laryngeal function needs to be good to consider the patient for organ preservation, which is absolutely correct. And so evaluation for swallowing and the speech evaluation is very essential before any organ preservation protocol.
Next question to Shiva sir. Suppose sir, this patient was a little advanced disease and we given an NACT, and after NACT, what you will see in the response, CR or PR, to decide further on the treatment, surgical versus radiation?
If there is a complete response, then probably I'll be thinking twice before doing a surgery. So the aim is always if we can preserve the larynx for the patient. So if there's a complete response, it's a good thing. We can do an assessment, look for the cartilage status. Sometimes, many times after NACT, we have seen the sclerosis of the cartilage. I mean, if you're talking about advanced disease beyond the T3, that is I'm saying. Yes, so if there is a complete response where we have sent for NACT, because it's a borderline resectable, and then there is a complete response, then we will again reevaluate if the patient should be considered for surgery or some non-surgical treatment option, because always the priority is to save the larynx when possible. But then that situation happens very rarely. So most of the times in an advanced situation where if there's a good partial response, then initially we would, like most commonly, the reasons for NACT is when the lesion is coming close to the lower pole of the tonsil or involving the base tongue or the extensive soft tissue disease, so on and so forth. So we would like to see if we can get a margin in all these concerns that we had, for which we had sent for an NACT, where we can go ahead and do an R0 resection. And if that thing can be achieved and with an with that kind of a response after NACT, definitely we would go ahead with surgery. So after your NACT, we would definitely do again a DL scopic evaluation to assess map the mucosal disease, and then decide about the operability.
I have a question for Sir Bani. Ma'am, how much you would stress upon end stage in this particular case, because the patient is a candidate for radical CTRT or cydical RT. So how important the end stage becomes? Like if the radiologist has not confidently reported nodes, or the extranodal spread is not confidently reported, and clinically there's no extranodal spread. But how important then the extranodal spread becomes on a radiology? Because N3 versus N1 would be a different ballgame.
See, Abhishek, to answer that question for you, if I have a node besides the ENE by size criteria, by shape criteria, and by what we consider as an involved lymph node, a significant lymphadenopathy, besides the ENE, I would consider as significant, especially this site that we are talking about is hypopharynx.
Okay, ma'am.
So I would not only look at you reporting on ENE, but I would also look at the various other criteria to call this a significant lymphadenopathy in the head neck region, considering that the primary is the hypopharynx.
So, ma'am, but if we report ENE on radiology, would there will be a change in management of this patient?
Not really, Abhishek, because Shiva may correct me if I'm wrong. Is that besides what you report as ENE, we would also like to look at what was the involvement actually of the various other structures in the vicinity before making the final decision. Okay. And the other thing that we would like, because clinically we would look at whether the node is fixed or tethered, what is the involvement or its relationship to the carotid artery, things like that before we take a final call, on resectability versus unresectability, if that's the issue. And also, as you yourself would be able to tell us, the reporting of ENE on radiology may not be as great as pathologically.
Thank you, ma'am.
Sarbani ma'am, suppose we give an NACT and there is a PR, say, then what will be your approach? Whether you like to go ahead with CTRT or you will refer to surgical team?
I would refer to surgery only if there is gross cartilage erosion, a dysfunctional larynx. Otherwise, I would go ahead with CTRT.
See, again, there is there's one issue. I mean, it's a debatable area wherein exolaryngeal spread without cartilage erosion. That is when there is exolaryngeal spread to the thyroid membrane, and sometimes the patient may have intact laryngeal function. And there is definitely, it can be debated as to whether the patient can be, it's a T4 clinically, but then it's because it's exolaryngeal through the thyroid membrane and not through the cartilage. So should you go ahead with a total laryngectomy or should you go ahead with CTRT? So multiple things have to be considered here. Whatever limited data that we had showed, even in a T4, even if it is T4 because of exolaryngeal spread through the thyroid membrane with an intact cartilage, and even the function sometimes is intact, that is if there's no aspiration, surgery may add to the the survival than non-surgical option. I think it's debatable. That is what we have found in one of our studies. It's a retrospective, of course, I do agree, but then that has been my observation as well.
Nandini ma'am, any of your opinion?
Sarbani ma'am, I have a question. Madam, you told like in locally advanced hypopharynx, in N2, N3 disease, we would like to consider if it is N3 bulky node, NACT followed by CTRT. The intention of giving NACT in that situation is to decrease the field of the radiation only, or is there? I don't think in like any benefit, like is there any benefit of decrease in local recurrences, or if it is for survival? For mainly our intention is to decrease the extent of the RT volume only, in that case the giving of NACT.
No. So so your thing is, what is the purpose of NACT if I'm going to do CTRT? So in hypopharyngeal cancers, the purpose of doing NACT would be to some extent take care of micrometastasis. And if you ask me about volumes, yes, but the volume, if you ask, the regions that need to be treated post NACT don't change. Okay, so if a level 2 was involved, I would still include the level 2 for radiotherapy, even if it responds. But yes, the volumes of radiotherapy would become smaller. Also, during radiotherapy, my need for doing adaptive radiotherapy, which means multiple changes in plans, would also become much less. So there are three reasons. One is to deal with micrometastasis in advanced nodal disease. The second is it would be a surrogate, like a bioindicator of whether this patient is going to actually respond to RT or CTRT. The third is it would reduce the instances of adaptive radiotherapy while the patient is on radiotherapy. And thirdly, which is a minor point, would be that our volumes would be slightly less, but the regions or the extent of the radiotherapy volumes would still remain the same. Is that clear?
Yes, ma'am. Yes, ma'am. But micrometers, that's like, I exactly not remember the trial name, but as such, with respect to the numbers, was like survival or laryngeal preservation rates, like salvage laryngeal preservation rates and local recurrences. With respect to that, if I'm not, maybe I'm not wrong, maybe I'm wrong. NSCT followed by CTAT versus CTAT is equal. I think there is no advantage of adding NSCT with respect to CTAT. Maybe
Okay, so if you look at the URTC trial on hypopharyngeal cancers, which is the only available evidence, what it simply tells us is that there is a definite advantage of giving NAC or induction chemotherapy when you talk about laryngeal preservation, though of course the rates are much lower. If I'm not mistaken, it's 21% versus the 67%, 31% versus the 67% in the Veterans Affairs study. But there was also an advantage of reduction of the distant metastasis. So there is an advantage, because if you see the volumes of proportion of hypopharyngeal cancers in other trials of organ conservation are much, much lower. So the URTC trial is the only trial that we can take recourse to. And here the arm of non-surgical treatment was RT alone and not CTRT.
yes, ma'am. Yes, ma'am.
Okay, thank you, ma'am. So with respect to, as ma'am already said, before going to treatment part, we should evaluate person definitely for speech and swallow and further chemo fitness. So I would like to ask Dr. Balaji to just enlighten us about the role of speech and swallow evaluation in the case of hypopharyngeal cancer.
I think Dr. Balaji has left. He put a message, no?
Okay, ma'am. Okay. Then next part is this because we may plan this patient with a say concurrent cisplatin. So evaluate the patient for fitness for the cisplatin, and one part is the audiometry. So I would like to ask Jitesh sir to just enlighten about this audiometry part, how to read this audiogram.
Good morning, everyone. So this is a sample audiogram which says that how the speech sounds are being heard in this area in an audiogram. So you can see usually we are hearing around 30, 40, and around 60. All the speech sounds are being heard within that intensity range. So if it crosses the thresholds, the regular thresholds which we obtain from the patients, if it is going beyond the speech banana, the patient is going to miss some sounds. So we need to take care of that. If before treatment, if the patient is going to is having any difficulty in speech understanding, so for that we need 2-3 audiological tests. One is pure tone audiometry, and the second is we can do OAE, and third we can do speech audiometry. So as of now, we don't have a speech audiometer over here, but we are. I am specifically mentioning if there is any patient-reported speech understanding difficulty, and that too if it is mild, moderate, or significant, or if it is severe. So we should there is no particular guideline how to go with treatment, but at least we can consider for any chemo reduction or alternative chemo medicine in case there is a mild or moderate hearing loss that is impacting his or her the patient's speech understanding. So this is an idea in this picture. This shows how the hearing might affect the speech understanding. So mostly high frequencies have the consonants, and the low frequencies have the vowels. And if it is going beyond 35 or 40, that which is mild hearing loss. So in that case, we should consider for any alternative dose, or in below that, if it is a normal or minimal hearing loss, or sensorineural or conductive, we can the hearing there is not very much chance that the patient is going to have any hearing difficulty or speech understanding difficulty. But we don't know. There is significant difference in individual differences also. But pre-treatment, when we are considering chemo fitness, so it is mild or moderate hearing loss or more than that, and most importantly, it should affect the the mild hearing loss is around 40. So 26 to 40. If it is normal or slight hearing loss, we should not be very much bothered about. But if it is getting more than mild hearing loss, and sometimes the hearing loss will be, the pattern of hearing loss will be little complex. Low frequencies will be normal, and high frequencies will be little more, will have higher thresholds. So in that way, we need to ask the patient, or whether the patient is having any speech understanding difficulty, if it is mild or moderate or significant, or we can go for a speech audiometry. And the speech audiometry, if we don't have we are not doing speech audiometry, we don't have enough infrastructure. But if we are going for a speech audiometry, the criteria we should follow, as of now, there is no evidence, but what we are following in other audiological clinics, like SRT, speech recognition threshold, more than 40 dB is significant to consider. Okay, there is very much impact in speech understanding because of hearing loss. So these are the grades, degrees of hearing loss what we are usually following. So mild hearing loss 26 to 40 dB. Then for moderate hearing loss 41 to 55, and moderate severe 56 to 70. Severe hearing loss is 71 to 90, and more than 90, it is profound hearing loss. So the audible range of hearing loss, hearing is around mild to severe. More than severe, it is not useful hearing. So we should see, okay, if the patient is having some amount of useful hearing, and we can consider, okay, if the patient is going to have, okay, after post treatment, the patient might hear after treatment also, then we can at least somehow think that, okay, patient is going to hear. So we need to be little careful about that while planning this for chemo. And not only degree, there is patterns of hearing loss, so and types of hearing loss. So in this picture, you can see this is a normal hearing, and this is a conductive hearing loss. Then C1 is a sensorineural hearing loss, and D1 is a mixed hearing loss. So in here, we are seeing the different types of hearing loss, how it can. So in normal hearing loss, we don't have to bother very much. But in conductive hearing loss also, because the sensorineural hearing, the cochlea and the BC sensitivity is normal. And in that case, it is sometimes, or most of the time, it is temporary, and some management can be done by ENT surgeon, or we can, it is useful. Means after hearing aid fitting, a person can hear. So in sensory hearing, you will have to be, because it is irreversible. Here also, we have seen mixed ear. So most we should be concerned about more when it is a sensorineural hearing loss or mixed hearing loss, and more of a in a mild, the degree should be mild or moderate, then we should be more concerned. And sometimes we should concern also about conductive hearing loss when the age is very much, because in for above 50 or like that, the conductive hearing loss, for conductive hearing loss, the surgeon might not suggest for a surgery, or the hearing loss may not reversible. So in that case, we should also consider, okay, the patient is not going to hear even after ENT management. So here there are different nature of hearing loss. So even if there is a mild hearing loss, that can affect the speech understanding when it is sharply sloping or even gradually sloping. So we need to consider even if it is mild hearing loss or minimal hearing also, we should ask, okay, whether your speech understanding is good or it is speech under there is speech understanding required, and how much is the speech understanding. So if we have a audiological test like speech audiometry, then we can consider that, or we can right now I am mentioning specifically, okay, if any patient is having significant difficulty in speech understanding, and accordingly medical oncologist can think about any treatment suggestion according to the hearing loss. So these are different types of natures of hearing loss. So gradually shifting when there is a 5 dB loss in different frequencies. When you go from 500 Hz to 250 Hz to 8 kHz, there is a loss decrease in threshold of 5 dB per octave frequency. Then if there is sharply sloping, there is 15 dB more loss when you go from 250 to 8 kHz. And there is a flat loss. Flat loss is a little bit less complex than sloping loss, because if your hearing aid is fit, then mostly the patient will hear in when compared to the sloping kind of hearing loss, because in sloping kind of hearing loss there will be much difficulty in differently amplifying different frequencies, and there is notes. So you should consider those notes, whether it is a huge note. So in that case, also patient is going to have some amount of difficulty in speech understanding. Okay, can you please go to next slide? Yes, this is an audiogram which of our clinic. So in this right side is plotted with red pen, red ink. Then left side is plotted in blue ink, and the below one, which one, the circle one is for right, and the crossed one is for left. And this circles, circle ones represent air conduction threshold for right ear, and the cross one represent the air conduction threshold for left ear. And these are air conduction thresholds are connected with bold lines, and the arrow symbols are for bone conduction thresholds, and these are connected with dotted lines. So here we have a very the patient does not have any pre-treatment hearing loss. So in this right ear as well as left ear, so air conduction is normal, and the bone conduction is also normal. So, and when we see, we need to also see the tuning of test. RINA is positive. There is no any conductive hearing loss. So that's why RINA is positive in both ears, and Weber is centralized. So when Weber is centralized, we should do the bone conduction threshold of the better ear in the Pureton, where the Pureton audiometry, the air conduction thresholds are better. So in this audiogram, the Pureton, the air conduction thresholds are better in left ear. So we have plotted the bone conduction thresholds of left ear, and there is no airborne gap, saying that indicating that there is no conductive or mixed component, and it is a normal hearing audiogram. Yes, so we should not be very bothered about this audiogram. Next, in this is a audiogram. There is a minimal hearing loss, and again there is air conduction thresholds are 20. It is average. So when we see the average of 500, 1K, 2K, 4K, so it is 21.25 in right ear, and in left ear it is 21.25 again. So it falls in minimal range. So when it is minimal hearing loss, earlier I said it is not very much significant. There will not be very much significant difficulty in speech. That's why I have not mentioned any difficulty in speech understanding. And we can measure the bone conduction threshold of any ear when it is a symmetrical kind of hearing loss. So here it is a symmetrical kind of hearing loss, and the bone that's why, and there is no no conductive or mixed components. That's why the relay is positive in both the ears, and wherever it's centralized, so we can take bone conduction threshold of any side here, and that would represent the bone conduct cochlea and the function of inner ear for the both the sides. So it is a bilateral minimal sensorineural hearing loss when there is no airborne gap in any of the ears. So this is a different audiogram which says there is a mild sense. This audiometry has been done outside of KMC. That is, I think before chemo or after chemo they have not mentioned. But you can see a mild sensorineural hearing loss with moderately severe hearing loss. So in this audiogram, it is sloping kind of hearing loss. So it is very difficult to name it. It is very difficult to diagnose it with a single degree. So that's why in low frequencies there is a mild hearing loss. In high frequencies that has gone to moderate severe kind of 50 or 60. So it is difficult to. That's why they have mentioned bilateral mild hearing loss, mild sensorineural hearing loss. Along with there is a moderate severe component at high frequency. What we are doing in our clinic is we are mentioning the degree to maintain uniformity among the degrees to understanding more better. We need to see the audiogram. So we are directly mentioning what is the degree according to the Peotone average. So if it is 500, 1K, 2K, 4K, the average falls into mild category. So we are directly mentioning mild hearing loss, and with a dip in high frequencies, or if it is a sloping, or if it is steeply sloping, or if it is a kind of bilateral or unilateral, or if it is a conductive or mixed. So here it is sloping, but sometimes it will not be purely sloping. Some frequencies will go up and down. It will be a zigzag pattern. It will be a rising pattern. But actually we cannot diagnose. We can give a proper diagnosis based on the nature. That's why we need to directly see the audiogram. Most of the time the degree is indicative of the actual hearing level, but sometimes it will not. So we need to see the audiogram, and that too in each and every frequencies. So what this audiogram has shown, it is the diagnosis is different. What we are following in our clinic, we are mentioning the degrees, and along with that the pattern of hearing loss, sloping, moderate sloping, or steeply sloping, or it is along with that the understanding of speech understanding, patient reported. As well, sometimes we are referring for speech audiometry, but more often we are writing the patient reported speech understanding, whether it is mild, moderate, or whether it is going to affect the speech post treatment and speech understanding. Can you go to next slide, please?
Sir,
Yes.
that all slides we have, sir.
Yes, sir. Any questions you'd like to? Hello?
Any student having any question? Shashwat, Abhishek, Darshit.
Most of the time, I would like to say one thing. Most of the time, the pre-treatment hearing hearing evaluation, the audiogram says there is.
Is there VTB today? I just saw the message yesterday night only, and I thought it would be 2 weeks late.
Most of the time, hello, can you?
Yes, sir. We can hear you.
Yeah. Most of the time, the pre-treatment hearing audiogram says there is a normal hearing or a minimal hearing. That should not be confused. Okay, that is significant. Minimal hearing loss will not have more because the classification of hearing loss was adopted from abroad. So mostly in 15 or 25 dB of hearing loss will not cause them more difficulty in speech understanding. And we are not very much bothered about my minimal hearing loss in India, because we have so much noise, and many people are not very much bothered about minimal hearing. So if I ask a patient of hearing minimal hearing loss, okay, do you have any hearing problem? You will directly say, no, we don't have any hearing loss. So in India, we are following what patient says. Okay, patient wants, okay, if there is some amount of hearing loss. So I am specifically mentioning, if even after a mild hearing loss, the patient says, okay, I am having some amount of hearing loss, hearing difficulty, speech understanding difficulty, then I am specifically mentioning. But after mild, say like moderate or moderate severe, there will be definitely above 90% people will say, okay, I have some amount of difficulty in speech understanding, moderate severe, or severe hearing loss. So we should consider those hearing, those levels of hearing to be significant. And one more thing I need to say, because we are not following grades of hearing loss, which is in abroad, many clinical trials and oncologists, they are considering grades of hearing loss, because grades of hearing loss are more fine to tap the issue and tap the loss in hearing loss as the shift in hearing loss as we progress to the treatment. So it is 10 dB or 20 dB. Also, we are able to identify, and we are able to mention, report that, okay, there is grade 1, grade 2, like that hearing loss is increasing. So we can consider that. But here we are not following for adults. We are following for, we have started mentioning for pediatric patients, pediatric population. But for adults, we are only considering speech understanding difficult. And if in latter, if we are getting a good odometer or high frequency assessment facility, we can incorporate that grading also. As of now, CTC has been considered, but in what we think, a tuned grading system has been newly proposed and it developed. It is a very good. In any other class, I can present that the different grading systems and the cross forms of the grading systems.
Yeah, sure, sir. Okay, thank you, sir. Next question to Neha, ma'am. Ma'am, suppose this patient underwent upfront surgery, either for a very early disease or for advanced disease. So, what all features you see means report in the pathology HPR report, which will help us to decide further adjuvant treatment.
So if this patient underwent surgery, the specimen will be looked at in its entirety for all the cap related. There are what we do is reporting according to the cap related parameters, and those include core elements and non-core elements. The core elements are essential part of the report, which in this case will include tumor size, tumor site, main involving structures, tumor type, tumor grade, and these are the basic, and of course the nodal, and based on these and the nodal status, the section will also be done. So metastasis or not in the neck, with or without extranodal extension. So all these are essential part of the report. These are core elements, and of course based on these we will have a pathological staging of the tumor, the P staging of the tumor, in which again we'll have the same categories for, and the nodal staging of the pathological categories is different. For us, extranodal extension comes in two stages, PN2A and PN3B. 2A is a single node 3 centimeter or less, which is showing extranodal extension, and there is no other node in the neck dissection which is positive. And 3B is if there is even a single node with metastatic focus which is showing extranodal extension, and any other node positive in the entire neck dissection, then that becomes nodal stage 3B. So basically core elements and non-core elements. One pathology related parameter, and there were multiple questions in the chat box related to that also, I would like to highlight here, is that P16 in this situation is not equivalent to an HPV mediated status. Neither do we know what is the significance of P16 positivity and HPV mediated, what is the correlation between the two in hypopharyngeal cancers in our population. And as I've already written in the chat box, this data is very variable. If you see European data, there are studies which are saying 70% of their hypopharyngeal cancers were P16 positive and majority were HPV related, whereas there are other ethnic areas where the correlation is less than 10-20%. So that is why here we need to know whether this is HPV mediated in our situation, whether this is that can only come from HPV genotyping in this. And even after that, we do not know the significance of HPV mediated status in this in the hypopharyngeal cancer per se, whether or not these patients behave better than the non-HPV mediated hypopharyngeal cancers. That part is yet to be clarified. We don't have our own data, and the data in literature is quite conflicting and regarding this.
Okay, thank you, ma'am. Actually, we are already very over time.
Madam,
So let's
last doubt. Madam, I have one question. Madam, in a head and neck squamous cell carcinoma patient with a single 2 into 2 centimeter lung met lesion, we did a biopsy from that lesion. It came out as squamous cell carcinoma. Is there any possibility to differentiate between whether it is primary or it is a secondary from the head and neck? Like histopathologically or any IHC marker, is there any possibility to differentiate that lung lesion?
So that's a very good question. And if that there are 2-3 possibilities here. It is not a no in every situation and not a yes in every situation. Absolutely. So there are different situations here that we are looking at. So if your head and neck primary was an oropharyngeal, which was P16 positive, we know that majority of lung squamous carcinomas are not P16 positive. Okay, so in that situation, P16 might help you to differentiate whether these are two different primaries. Okay. Besides that, we will definitely look at the morphology. If one is morphologically a moderately differentiated or a well differentiated tumor, and the other is a totally poorly differentiated or a very different looking tumor, then also it can indicate to us that probably these are two separate individual primaries rather than being metastasis of one from the other. But and there are multiple, actually nowadays there are multiple NGS based tests actually which are finding signatures in tumors, and this was being discussed. We had this European Congress of Pathology meeting in which they were actually showing a study in which they tried to identify tumor signatures which are similar tumor types, which means squamous carcinoma of different types. However, identifying tumor related signatures or at a molecular level and at an AI based level to identify a tumor of one site from the other. And one AI based study showed a very good accuracy of identifying these head and neck related squamous carcinomas different from the lung related squamous carcinomas. But right now, as I said, all these are mostly experimental, and in practice, only if one is P16 associated, that is the situation in which it may be helpful.
P40, P63 will not help now. They may come
squamous markers. These are pan-squamous markers. Current immunohistochemistry, squamous of all sites will show you epithelial marker and squamous related markers which are P63 and P40 positivity. So this will not differentiate squamous of one site from the other. I know initial literature on P40 said that P40 positivity is specific for lung squamous carcinomas and all that, but we are far beyond that. P40 is a pan-squamous marker. Wherever you will see squamous carcinoma in the entire body, whether it's cervix, lung, head and neck, larynx, P40 will be positive.
Abhishek sir, the same question, like radiologically, when there is a lung lesion in a known case of head and neck carcinoma, how we can help to whether it is a primary or it is secondaries, like number of lesions or location of the lesion? Is there any catchy things which we can? Hello, Abhishek sir.
Abhishek sir is not there. So actually we are already over time. We'll go ahead with the last part of this. The one last question to Shiva sir. Sir, which group of patient you will consider upfront surgery?
Definitely, a dysfunctional patient with a dysfunctional larynx. I mean, it can be T3 or a T4. Most probably, predominantly, it is a T4 lesion who have a dysfunctional larynx. So definitely for a T4 larynx and a dysfunctional T3 larynx as well. I hope that answers the question.
Yes, sir. Thank you, sir. And one last question to Sarbani ma'am. Ma'am, if patient going upfront for surgery, which patient you will consider for adjuvant RT or CT-RT?
So the typical indications would be on histopathology T3, T4 disease with perineural or with perineural invasion or lymphovascular emboli, involvement of the lymph nodes with ENE, or depending on whether it is more than N2A. But a T2N1 may also sometimes be considered for adjuvant RT. So when I say T3, T4, I mean the extralaryngeal extension, involvement of the cartilage, involvement of the soft tissue, strap muscles, and things like that. And of course, if the cut margins are close or positive.
Okay, thank you, ma'am. I'm last, ma'am. Which is the RT modality we prefer? IMRT, conventional, or this proton?
Oh, so okay. So now I'll tell you, if this is we are discussing a case in, say, for an exam. So we are talking about ideal circumstances. Okay, we are not talking about logistics. We are not talking about restraints of resources and things like that. So if you're talking about ideal circumstances today, I would try to treat them with IMRT, with or without IGRT. All right. But if you talk about logistic issues, or if you talk about a setup where you don't have an LA, or where you don't have, or a patient has to wait for long to receive radiotherapy, you can do equally good. Rather, you can do optimal radiotherapy even using telecobalt. But yes, there you have to pay attention to using tissue compensators to be able to deliver higher doses. You have to plan properly. Like, if you have a post-op larynx, you need to cover the tracheostomy adequately, the tracheostoma adequately, things like that. But yes, the ideal scenario, you would talk about IMRT with IGRT of some form.
Okay, thank you so much, ma'am. And the last question to Nandini, ma'am, regarding chemo part, ma'am. So in NSCT and adjuvant setting and concurrent setting, can you just enlighten us about the chemo regimen we prefer? Nandini, ma'am.
I'll take it, Ajay. I'll take it.
Okay, sir.
So for concurrent, 3 weekly cisplatin, if possible. If not, then weekly cisplatin, and that may be dose may be 40 milligram per meter square. If not possible, 30 milligram also, in case you have a concern regarding this, 40 milligram per meter square. And if it is cisplatin ineligible, then to consider the targeted therapy. 2 of them are there, cetuximab or nimatuzumab. If we consider weekly cisplatin, may adding nimatuzumab, there is some decent data on that. One can consider adding it. Coming back to again cisplatin ineligible, apart from the option I said, we have the option of 5-FU carboplatin. We have the option of 5-FU hydroxyurea. We have the option of paclitaxel carboplatin, and also the option of docetaxel cetuximab. Depending upon which kind of reason is there for the being cisplatin ineligible, one can consider choosing it. Like, for example, if the patient had only sensory neural deafness and we don't want to use cisplatin, 5-FU carboplatin is a very good choice. And again, I'll say, depending upon individual reasoning, one can choose one of them. Coming to neoadjuvant chemotherapy. In neoadjuvant chemotherapy, the choices what we have is 5-FU platinum, DCF, that is taxane plus 5-FU plus platinum, or taxane plus platinum. if the patient is absolutely fit, and one can consider three chemotherapy regimen, that is DCF, but one has to see that patient is fit to receive that. If not fit, 2-drug regimen is absolutely reasonable choice, because remember, the idea of neoadjuvant chemotherapy here is to choose the right patient for giving organ preservation in this setting. So it does have a limited role in adding life to the patient. When we are thinking that we want to add life to the patient, 3-drug regimen will be the choice. It does also lead to some more organ preservation, but 2-drug regimen also, if patient is not fit for 3-drug regimen, gives you a reasonable choice to choose those patients whom you can choose for organ preservation. So for unresectable disease, or where you want to use 3-drug regimen to add life or more organ preservation than 3-drug regimen, but again not fit, then 2-drug regimen are reasonable choices in this setting.
Can I add something here to what Dr. Kumar has said? Like when you are using docetaxel, please be aware of what is going to happen during radiotherapy too. Okay, please keep that in mind.
So so if you use docetaxel, idea will be that if you're using 3-drug regimen, if you consider RT alone, that is a fair choice. So what we get confused about it when we want neoadjuvant chemotherapy as an organ preservation protocol, remember, subsequently chemoradiation is not necessarily has to be given. Don't use cisplatin, use only RT, and then you will have a reasonable outcome. The problem is that when we want neoadjuvant chemotherapy followed by CT-RT for organ preservation, this has not been shown to be a good idea. So organ preservation, chemoradiation, or neoadjuvant chemotherapy followed by RT may or may not you want to add non-cisplatin based chemotherapy to it subsequently. Then you will have a reasonable outcome. That's all. That's what you wanted, Ajay?
Yes, sir. Yes, sir.
Thank you.
Thank you. So one last question for the today's. Suppose we treated this patient, and how do we follow up this patient in OPD for recurrence and for rehabilitation? To Sarbani ma'am and Shiva sir and Kumar sir.
So, at follow-up, first and foremost, I think I would do a little bit of what you call history taking, and that is essentially to assess the status of his swallowing and speech. So I would ask for complaints or signs and symptoms suggestive of aspiration, if at all. And since this patient has been treated with RT or CT-RT, you would also want to ask some questions regarding, change in diet, what can he or she eat properly, dental complaints. That's another important thing that you have to remember for all these patients who are planned for definitive CT-RT, and that is dental prophylaxis prior to starting radiotherapy. Okay, please remember that. And the other thing is, of course, signs and symptoms suggestive of aspiration, whether there is a change in the dietary habits of this patient. Of course, intolerance to spicy food will remain for these patients. And importantly, of course, cessation of all habits. That's something that you should ask at every follow-up, so that you can re-emphasize and reiterate the importance of not going back to the old habits. The next thing, of course, would be a detailed clinical examination, which would be examination of the neck as well as a Hopkins or a fiber optic laryngoscopy to assess the status of the disease and the status of the cords. And then I would do imaging only if there is, I would do it first at the first follow-up to document response to your non-surgical treatment. Thereafter, I would do it if and when there is suspicion of a recurrence or distant metastasis. And rehabilitation at every follow-up, we typically send the patient to the speech and swallowing therapist again for re-emphasis and reiteration of the swallowing exercises, speech exercises, and also to the nutrition clinic and the dentist. Now, if patients have significant edema or fibrosis, you may also want to send them to the occupational therapist and the physiotherapist.
Okay, thank you, ma'am. Kumar sir or Shiva sir would like to add something else?
So, same thing, just to, to make it easy to remember, when you have a patient, think about the disease, think about the complication related to whatever we have done. It can be surgery, it can be radiotherapy, it can be chemotherapy, whatever. So they do have, all of them has complications. To watch for it. Third, to see the recurrences. Third is the second, primary. In this, setting, if the patient has, and fourth, rehabilitation. That may help remember, maybe in a structured way, but the same thing what Dr. Sarbani said.
Okay. Thank you, sir. And for today, we will conclude now. And my apology for we are so late. And I'm very thankful to our respected faculty members today. So improving our knowledge regarding the hypopharyngeal management and in clinics. So we'll conclude today. And thank you all.
So sorry, can I just ask one quick question, because I think I missed that part. Kumar, what was your response to that post NACT with 3 drugs? Is it all right if the patient is compromised to just give RT alone?
Yes, not compromise. In fact, that should be the by and large the plan. If I'm giving NACT with 3 drugs or maybe 2 drugs with cisplatin for 3 cycles or 4 cycles, then subsequently, based on response, if you choose RT as alone as an option, the outcome for organ preservation for 3 drug will be similar what we have for CTRT.
Okay.
The problem is that when we give CTRT after NACT, then it becomes tough to give CTRT and we end up compromising the RT. So I totally agree with your thought process that after we give NACT, we should find out ways and means not to compromise the RT.
Okay.
And one of the way to do is avoid giving cisplatin. You want to add something, you can add something, but if we can decide only RT, then it is okay. And in fact, this was the same what we had seen with the a study when they compared that was RTOG 911, where the organ preservation was less, overall survival was similar, and subsequent study when compared 3 drug versus 2 drug, then organ preservation increased by 13-14% for NACT, but in both of them, the approach was NACT followed by RT. CTRT, because we are so keen on CTRT that we end up planning for CTRT after NACT, which ends up compromising the RT, which we should be careful about. If we give, we need to be careful that we don't compromise the RT. And that is what our concern was, Sarbani, isn't it?
Yeah. No, and so, and I guess today we can substantiate this by talking about the meta-analysis that we have, right?
Yes, true.
Yeah, okay. Yeah, okay.
Okay, thank you, ma'am. Sir, should we stop here today?
Yes, I think so. We have really gone beyond.
Yes, sir. So thank you all.
Thank you.
Seniors.
Thank you.
Yeah.
It was a good discussion. Yeah, bye.
Thank you, ma'am. Thank you, sir.